What if your bone marrow slowly turns into scar tissue and just can't produce blood cells properly anymore? The body then desperately tries to compensate outside the marrow, which leads to severe anemia, extreme fatigue, weakness, abnormal blood cells floating around in circulation, and a massively enlarged spleen. How does the body handle it when its most crucial supply chain is completely severed? It's a fascinating, catastrophic physiological crisis, and it plays out exactly like a medical mystery.
Welcome to MedNexus. In today's explainer, we're unraveling the mystery of myelofibrosis, one of the absolute most important myeloproliferative neoplasms you'll encounter in hematology. We're going to break down exactly how this disease turns healthy marrow into dense scar tissue, forcing the body to desperately scramble just to keep you alive.
Okay, let's dive right in. Here's our roadmap for today. First, we'll look at how the bone marrow fails. Then, how scarring takes over. After that, we'll cover the clinical picture, run through the key diagnostic clues, and finally, discuss treatment and outcomes.
All right, starting off with part 1, the bone marrow fails.
At its core, myelofibrosis is a chronic myeloproliferative neoplasm. Now, what does that actually mean in plain English? Basically, it means there's a progressive fibrosis or scarring of the bone marrow space. As this thick, fibrous tissue builds up, it physically crowds out normal hematopoiesis. The primary blood factory is just effectively closed for business. But, you literally can't survive without blood cells. So your body goes into this extreme survival mode and starts opening up makeshift factories elsewhere, primarily in the spleen and liver, just to keep production going.
Now, this condition comes in two distinct forms that we need to compare. First up is primary myelofibrosis. This one arises entirely on its own due to a clonal stem cell disorder, and it's very often associated with a specific genetic marker, the JAK2 mutation. Then we've got secondary myelofibrosis. This doesn't start from scratch. It actually happens as a downstream progression after other existing blood conditions like polycythemia vera or essential thrombocythemia. But really, whether it's the primary genetic trigger or a secondary progression, the end result is exactly the same: relentless scarring.
Let's move right along to section 2 and see how this builds, how scarring takes over.
So how does this factory get shut down? It happens in 4 logical steps. Step 1, it all starts with the clonal proliferation of abnormal hematopoietic stem cells. Step 2 is where the real trouble begins. These abnormal cells, specifically the megakaryocytes, start pumping out cytokines, things like PDF and, crucially, TGF-beta. Now think of TGF-beta as this loud alarm bell that sends fibroblasts into absolute overdrive, making them aggressively lay down thick scar tissue. That leads straight into step 3, the actual bone marrow scarring. The normal, healthy space is completely replaced. Finally, step 4, extramedullary hematopoiesis. Since the marrow is scarred shut, blood production is forced to shift out of the bones and directly into the spleen and liver.
If we look at the pure cause and effect here, it's pretty much a perfect equation. TGF-beta release causes fibroblast activation and fibrosis. That bone marrow fibrosis directly causes decreased hemopoiesis inside the bones. And finally, that catastrophic bone marrow failure forces the spleen to take over blood production. Honestly, if you understand this chain reaction, all of the patient's symptoms are going to make total sense.
Which brings us perfectly to section 3, the clinical picture. All right, if you only remember one thing from this explainer, make it this. Massive splenomegaly is the absolutely most important clinical feature here. Because the marrow is closed down, the spleen takes on this huge burden of extramedullary hematopoiesis, but it just wasn't designed to handle that volume of work permanently. It expands so dramatically that in severe cases, the spleen can actually cross the midline of the abdomen or reach all the way down into the pelvis. It's an astonishing physical adaptation.
When we look at the full list of symptoms, everything tracks right back to that failing factory. The patient gets severe anemia, which means intense fatigue, profound weakness, and pallor because the makeshift spleen factory just isn't as efficient. We just talked about the massive splenomegaly. Then there are the constitutional symptoms: weight loss, fever, and night sweats. This is from the massive hypermetabolic state and that constant storm of cytokines raging through the body. And finally, bone pain. Why? Because those abnormal cells are desperately trying to expand inside a bone cavity that is rapidly filling up with rigid, unyielding scar tissue.
Moving right along to section 4, key diagnostic clues.
This is one of my favorite visual clues because it so brilliantly illustrates the mechanics of the disease. On a peripheral blood smear, you're going to see teardrop cells, or dacrocytes. It's a very characteristic finding. Just imagine a normal, round red blood cell desperately trying to escape a bone marrow that's packed tightly with fibrous scar tissue. As it physically squeezes through that biological concrete to get into the bloodstream, it gets pinched and misshapen, permanently taking on a teardrop shape. It literally tells a mechanical story.
Next up is a highly testable, classic hematology mystery, the famous dry tap. Normally, when a doctor does a bone marrow aspiration, they draw back rich, liquid marrow. But with myelofibrosis, they pull the plunger back and nothing. The needle pulls up completely dry. That's because the liquid marrow is just gone, entirely replaced by dense, solid fibrosis.
So, to quickly summarize the core diagnostic clues, you're looking for splenomegaly and liver enlargement on imaging, those classic teardrop cells, a leukoerythroblastic picture, which basically means stressed, immature red and white blood cells are being pushed into circulation way too early, and of course, that bone marrow dry tap. Plus, you'll often see the JAK2 mutation as a key molecular marker to lock in the primary diagnosis.
And finally, Section 5, Treatment and Outcomes.
Let's look at where this disease can unfortunately lead, as the downstream complications are severe. First, because of that massive spleen and liver involvement, the altered blood flow can cause dangerous portal hypertension. Next, as the marrow fails more and more, you see progressive, severe anemia. And perhaps most critically, the abnormal stem cells can mutate further, causing the condition to actually transform into acute myeloid leukemia, or AML.
So how do we actually treat this? Well, it depends on the severity. Supportive care, like regular blood transfusions, is crucial for managing the severe anemia. Pharmacologically, we use JAK inhibitors, like ruxolitinib. This is an amazing targeted therapy that directly reduces cytokine activity, which effectively shrinks that massive spleen and clears up those debilitating constitutional symptoms. In extreme cases, a surgical splenectomy might be needed. But it's really important to note that all these just manage the symptoms. The only truly curative option is a stem cell transplant, and that's generally reserved for younger patients or those with high-risk disease profiles.
Myelofibrosis is just a perfect example of how one microscopic change, just a little too much TGF-beta and some scar tissue, can completely rewrite the body's entire blood production map. It leaves you wondering, if the spleen can step up to act like a bone, what other hidden backups does the human body have waiting in the wings? Thanks so much for joining me on this explainer. Let me know, which hematology mystery should we break down next?